I'd like to thank Aaron and all the panelists as well, and it's good to be back talking with you again. And I'd also like to invite onto the stage the panelists for this next session on harnessing information technology for payment reforms. While they're getting set, I'll just make a couple of minutes of remarks to build right on what you just heard. As you've heard today, health IT is not an end in itself, but it is a meaningful and critical foundation, an essential foundation for making the real changes in healthcare delivery that amount to what we really want healthcare reform to achieve: better health and lower costs. That's real healthcare reform. It's not the policy changes in Washington and not what goes on in payment, anything else. It's the real delivery reform that matters. But as you all also know, without support from those policies, it can be very challenging to make these kinds of changes in delivery. I know from my previous experience working at CMS and meeting with many healthcare providers how difficult it can be when people are taking steps like trying to use health IT effectively to improve care and reduce costs. And it's like swimming against the tide, because many of these kinds of new and innovative approaches to care and systems changes are not reimbursed. They might take capital investment up front. They certainly take some time and effort of the staff involved to implement them effectively. Those costs may not be paid for. And then when these reforms, these delivery reforms actually work under traditional kinds of payment systems where you get paid based on the volume and intensity of your services, you lose again because you're reducing, in many cases, volume and intensity. You're avoiding the duplicative tests. You're avoiding the hospital readmissions. You're heading off the costly complications and all of the reimbursement that goes along with it. And so as you hear about these kinds of initiatives that are taking place in the Beacon communities, I think it is a very important question to ask: how are these going to be sustained? How are we going to take steps like using health IT to reduce readmissions, or using health IT to improve population health, or to improve the management and adherence to effective treatments for chronic diseases, or to use remote monitoring in a targeted and very personalized way? How do we make those kinds of changes sustainable? Because there aren't always going to be federal grants to keep these kinds of programs in place. They need to become much more integrated and intrinsic in the way that health care is actually delivered and in the way that it's financed. And that's what we're going to talk about to some extent on this panel, is how to move from the stage of investing in health IT and investing in the changes in delivery that go along with it to help make healthcare work better, to make those kinds of changes much more self-sustaining and reinforcing than they've been in the past. There are a lot of initiatives underway to help with these kinds of sustainability changes. You heard about many of them this morning as part of the National Health IT strategy. That includes a lot of specific components: meaningful use payments for health IT, an increasing number of CMS payment reforms, paying for quality reporting, including quality reporting off electronic systems, hospital payment reforms around reduced payments for readmissions and other types of bundling, a lot of more pilot-oriented efforts through the Center for Medicare and Medicaid Innovation. And in addition to what's going on in Medicare, many private insurers are now implementing changes in payment with the goal of supporting better care and lower costs. To help make these kinds of reforms work, though, it takes some real effort. This takes investment as well. Here, a critical step is being able to measure what you really want to support: better care and lower costs, not just volume and intensity. And there are a number of efforts underway to develop and implement more consistent measurement. That's a key goal of meaningful use payments. It's also a key goal of many private sector initiatives to identify different ways of paying based on improvements in quality, measured improvements in quality, based on measured improvements in efficiency, and the like. Now, a lot of these efforts are underway and are not yet very well coordinated or very well aligned, but that too is changing. In a pilot program this past year, we had an opportunity to work with a broad range of private insurers to move towards some consistent measures of performance based on using their claims data systems in more consistent ways. Those systems are now being considered and are going to be brought into the Beacon program as well, with help from Medicare. So in Beacon communities where there is an opportunity for private plans to move towards towards new mechanisms of supporting payment. Medicare data will be there to back that up. That's part of that idea of freeing the data that you heard Anish talk about earlier. So that's just one example, but there are other steps moving in the same direction of aligning payments with the kinds of delivery reforms that we want to support. And it's identifying those opportunities as well as the challenges to get there that is a big part of the discussion of this panel right now. And so to help us do that, I'd like to introduce all of our panelists. It includes Catherine Bruno, the executive sponsor of the Bangor Beacon Community and the Vice President and Chief Information Officer at Eastern Maine Healthcare Systems. Ms. Bruno has successfully developed information systems, strategic plans, and governance designs at 3 large complex healthcare organizations, and they're doing some work in Maine with some of their health insurers already. Also, Robert Steffel, the President and Chief Executive Officer of HealthBridge, an information exchange organization. HealthBridge is widely recognized for the customer-funded, self-sustaining health information exchange that it supports as part of the Greater Cincinnati Beacon. Also would like to introduce Dr. Christopher Shute, Professor of Biomedical Informatics at the Mayo Clinic and the Principal Investigator of a large portfolio of grants, including the ONC-funded Beacon Grant on the Minnesota Beacon Community Health Information Exchange. And then also Jim Walker, who designs and studies health IT systems that support safe and effective care. Jim's the Chief Health Information Officer at the Geisinger Health System, where he leads Geisinger's development of a fully integrated inpatient and outpatient electronic health record system, and he's also the Program Director of the Keystone Beacon Community. And then finally, Sabrina Heltz is the Senior Vice President of Healthcare System Quality for the Blue Cross and Blue Shield of Louisiana Health Plan. She's responsible for strategic and operational activities involved in improving the cost and quality of health care for members served by Blue Cross and Blue Shield. That affects the Crescent City Beacon community, but Louisiana Blue Cross is obviously an important player in broader health policy issues in Louisiana as well. So we're going to have this panel go like the previous panel. We're going to have some opening comments from each of our participants, and then hopefully some time for discussion, questions, and input from all of you. And with that, Catherine, maybe we can turn it over to you for some initial comments while I make my way down there. Thanks.
Sounds great. Good morning, everyone. I'm proud to be speaking from a community that has a robust healthcare delivery system with a history of collaboration and a strong foundation in electronic medical records. So we already have the pianos that Farzad talked about. In the Bangor Beacon community, we are working to improve the quality of care as well as the quality of life for people with chronic conditions. We will also reduce preventable emergency department visits and hospital admissions, and we will accomplish and measure this using care management in a day-to-day way for each patient, especially for transitions of care, robust electronic medical records in hospitals and provider practices connected through Maine's Health Information Exchange, Health InfoNet, and community-wide collaboration across the continuum of care. So that's the jazz band that Farzad talked about. So this takes a willingness to work together to find new ways, not just once, but on an ongoing basis, to better connect and coordinate care where it's needed most. The Bangor Beacon community has an energetic research team that will measure the improvements in quality of care, quality of life, and the use of healthcare services for the people with chronic conditions. And armed with this improvement data, we plan to approach payers to change the way that we are paid to support what we believe works: collaboration and care management supported by health information technology. Although it's still too early for hard data, we definitely have some wonderful stories to tell about patients whose lives have been changed by Bangor Beacon community interventions. So I'd like to share with you a story about David, who is 75 years old and living with his wife of 46 years. The past 8 years have been very difficult for the Dohertys, as David's been struggling with his health. He's been diagnosed with congestive heart failure and diabetes. David's nurse care manager works closely with him to help improve his health and, in turn, his quality of life. The improvements that he's made through diet and exercise have provided some real changes. Since they've been working together over the past 4 months, instead of spending every other month in the hospital, David has had no admissions to the hospital, none. David's care manager also says that working with her patients is now easier than it used to be because of the addition of electronic medical records. With the electronic medical records, she has all the information she needs at her fingertips. So regardless of which provider David sees for care, all of his diagnoses, treatment, tests, laboratory tests, medications are listed in the electronic health record. As for the Dohertys, they feel they've been given a lifeline. We know that health and well-being is more than traditional medical care. In a future environment in which reimbursement is increasingly linked to patient outcomes, we need to be able to implement techniques to support patients across the continuum of care. The addition of care managers at the primary care practices provides support to patients during many of the care transitions. They help interpret discharge instructions, provide medication reconciliation, and follow-up after discharge, as well as frequent monitoring and support to improve a patient's chronic conditions. We will measure these results, the improvements in patient care, and take the data to the payers to support our discussions about changing the way that we pay for health care. So I told a patient story. Now I'd like to give you some insight into the provider stories. Traditionally, healthcare has been delivered in silos within specific healthcare systems, so we've been playing our own pianos. Often information was not exchanged and care was not coordinated across these silos of care. So if we're going to address the care along the continuum, we need to hear from the care team members from multiple different organizations and systems. So we're getting experience playing in that jazz band. We're on the way to becoming patient-centered medical home and securing Level 2 certification. This includes creating the lists of patients with the chronic conditions that Farzad talked about. St. Joseph's hired a care manager through Beacon, and according to Dr. Krause, she is a crackerjack, and because she came from the home health environment, we now have a focus on getting outside the practice and into the community. According to Dr. Allen of Penobscot Community Healthcare, the old paradigm for medicine was that the provider made the decisions and the patients followed them. We now take a team approach to making decisions, and the final arbiter is the patient. Dr. David Prescott of the Acadia Hospital reminds us we shouldn't presume that a care manager, as the role is now defined, is the only solution to better care management. So we've been working intensely so that the information is readily available about medical conditions as well as psychiatric disorders, so that providers, with this help, are talking to one another and sharing a relationship that is clearly valuable to the patients and family. Another example includes the implementation of telemonitoring in home care. Patients will have a monitor placed in their home upon discharge from the hospital so that the patient's home care company is alerted if their indicators are out of range. We hope to prevent additional visits to the emergency department and readmissions to the hospital by seeing issues sooner. We are already engaging providers in discussions about payment reform and what a future environment will look like that would sustain all the advances we are making. We are leading strategy sessions with area providers, employer groups, and patient groups about accountable care organizations and other payment reforms, even while there remains much regulatory uncertainty. We see outcomes-based reimbursement as part of sustaining the performance improvements over time, and hence engagement now, not 2 years from now, is key. Using a deliberate, systematic approach, we are evaluating various levels of shared responsibility and the range of options for our community. The Bangor Beacon community is enjoying a time in which the technology is being recognized as the way we are finally going to be able to stay awake to the needs of our 150,000 residents in the Bangor area. We're getting our community engaged through social media and through a very active statewide advisory committee, and our television and radio stations are beginning to spread patient success stories. So in summary, We are building a system that is aware of and responsive to patients' needs across the continuum of care. The kinds of changes that will radically improve quality of care and quality of life are within our grasp through collaboration across the continuum of care and active care management supported by health information technology. So we'll be making beautiful music together.
Thanks very much, Catherine. Robert?
Well, the Greater Cincinnati Beacon community is really the Greater Cincinnati region, roughly a 50-mile radius around the city. It includes 16 counties across 3 different states, which introduces some new variables that are quite interesting. Roughly 2.2 million people, 6 major health systems, 22 hospitals in those health systems, and 7 or 8 others, depending on how you count. Roughly 5,000 active physicians in that service area. We have the good fortune to be building on a strong community collaboration that's been in place for some time, both in terms of measuring quality and doing public reporting, as well as the health information exchange structures. They've been in place for roughly 15 years. So what our Beacon community is trying to do is to use a shared IT infrastructure at the community level in conjunction with payment reform to see if that equals the kind of big changes that we'd all like to see. So in a nutshell, we're trying to evolve, not like a Mayo or a Geisinger is already there, we're trying to evolve a pretty normal community into a typically fragmented community, one of the major problems in healthcare, into a system that is much more reliable and that is specifically patient-centered. The community objectives of Beacon, you've heard these before, so I'll just hit them very lightly. We want to improve the management for adult patients with diabetes, including measuring the reduction in their ED visits and 30-day readmission rates. We have another component that's linked with Children's Hospital in Cincinnati that had an ongoing asthma collaborative that's been doing very well. We reasoned that by better coordination of care and getting them data that they don't have inside their walls now, that we'll be able to drive some better asthma numbers, including reducing ED visits for the asthmatic kids, reducing their school days missed, hospitalizations. So the clinical interventions that we're focusing on now is to move 20 practices to an advanced patient-centered medical home spot from where they are now. This will go, of course, with NCQA Level 3 certification, but also looking in great detail at their workflow and the process changes needed to make this work well, and using the diabetes D5 compliance numbers automatically flowed out of their workflow so that there's not nearly as much work in getting that quality data moving forward. The other piece that we're doing is trying to use a community registry to develop performance feedback for physicians on optimal diabetes care. This will encompass some 400 physicians and 15,000 patients. Beyond that, we are looking in much more depth at care coordinators in the ambulatory physician practices and really focusing, like many others, on transitions of care. I want to highlight transitions of care because it is such a compelling example of what will happen when we get the payment reform right. When the payment reform is driving toward a process change that also serves the patient, it can be a very beautiful thing, and it's interesting to see the energy and the innovation, even excitement around changing the readmission processes because of the changes in the way the readmissions will be paid for. Anyway, our community stakeholders in a community with lots of collaboration and lots of data flow realize that they are much more dependent than they had known previously on unknown organizations outside of their walls. Why did that readmission happen? And did it happen if it didn't come into back to their organization and let them pull it together? So there's excitement about being able to use the investment that we're making through Beacon to be able to pull together a baseline of data that actually goes back to 2006 to look at readmissions, but then to put specific clinical interventions in place to look for the root cause of the readmissions and try to prevent them going forward. The technology components that we'll be using and implementing through Beacon is taking the master patient index that we already have in place and moving to a much more robust way of tracking and letting our customers understand exactly who the patient is when they come in the door, but also with an eye toward being able to create a business rule based on the patient's identity, say as an example, and their selection of their patient-centered, their primary care physician essentially. If we can get that link in the master patient index and then automatically flow data based on a business rule, that will make the data more complete in the PCP office. And we're pretty confident we can do that on the existing data flow that we have. So if I were to summarize the Beacon work and how it's accelerating the preparations for payment reforms, there are really three key things that I think the Greater Cincinnati Beacon community is doing. First, the idea is to get the full picture of the patient. If we can move toward shared community infrastructure beyond the data exchange that we have now, but a robust infrastructure that will include the necessary data, including the data from CMS that I think we all heard offered earlier today, as well as the commercial plans and hopefully Medicaid, that being able to create that full picture of the patient will really be an important component of being able to support payment reform. The other idea is if we're going to do payment reform and try to engage at the community level, that same shared infrastructure can also dramatically reduce the cost of creating the infrastructure necessary for payment reform and eliminate a lot of the variables around, does this measure equal that measure? It also creates a great deal of flexibility as, say, the ACO or whatever payment reform model you have changes. Being able to change a select statement in how you view the data is much more efficient than having to go and recreate the data. And finally, the idea of having a critical mass in the community, being open to all stakeholders in the community to engage in this process, to drive to common business processes to collect and analyze the data, really increases flexibility. We think it'll lead to even broader engagement. And we really would like people to get to the state that they end up competing with the data, not for the data. So in conclusion, it looks to us like the right technology mix with the right payment reform can really energize transitions and move us forward.
Thanks, Robert. Dr. Shute? I'd like to introduce the Southeastern Minnesota Beacon with Olmsted Medical Center on bass, Winona Health System on percussion, Mayo Clinic keyboards, and all of our county health departments within the 11-county southeastern Minnesota area on vocals and harmony. The patients and members of our community are actually singing the song. Some of them are only humming along. They haven't quite learned the words. But it's been an engagement. There's about 500,000 people in southeastern Minnesota, so it's a small community, but the music's good. I'm going to describe 2 themes and then 2 hit songs that we've focused on, and some of the implications for our payment reform and who pays at the ticket gate. The themes are, of course, health information exchange. It's sort of an old song. I know a lot of you are doing that. But we thank you, ONC, for New Hin Connect, because that's become an infrastructure that we've implemented as a community by ourselves. We looked at some HIE alternatives and mechanisms and just decided to roll our own. So in terms of sustainability, it is integrated into who we are and what we are as a community. That frankly, the marginal costs of owning and operating and managing an HIE, particularly with New Hin Connect, are trivial. It's the social costs and the engineering and the engagement that are really the hard part. And fortunately, Beacon has provided a superb platform for that music to actually play and be orchestrated in an effective way. And so one of our major themes, of course, is health information exchange, just-in-time information for a patient and a provider. And in southeastern Minnesota, we do actually have a fair amount of distributed health care. We have small organizations that do primary care, and of course some larger organizations that do a lot of referrals. So the information exchange is non-trivial, even though we're in a relatively small area. The second major theme is patient data repository. We recognize that to figure out whether we're helping or hurting, whether our interventions are actually improving, we need a lot of information. And furthermore, that information has to be coordinated and organized. So we're in cahoots with Indiana and the Regenstrief crowd to take the infrastructure that they've put in place for the Indiana Health Exchange and adapt it for southeastern Minnesota, which creates de facto an information repository. We cheat a little bit because we're also involved in one of the SHARP programs, the SHARP program for secondary data use. So a lot of the artifacts and machinery and engineering of how to do that better, cheaper, faster, more securely, I might add, to maintain a repository of patient experiences gathered from our partners into a fairly carefully segmented representation of the community's health events, outcomes, and related activities enables us to either look at our own practices as a data warehouse in the shared infrastructure. That's quite useful to many of our partners, but more pertinently, with appropriate permissions and with appropriate agreement among our consortium, we can look across all of our patients. And the major deliverable out of that, of course, is when we do population-based health care. When we look at our panel of 1,000 diabetic patients, say, in a given area for a particular primary care provider, we can actually know what other services have been delivered for that entire population at other organizations. So our population health delivery is actually truly population-based. Now, to our hit songs. Asthma in children, of course, is one of our focus, and we're engaging all 47 school districts in the 11-county area who are participating with enthusiasm. This was surprising. And the school nurses are actually quite involved and engaged, where we have delivered asthma action kits to all of those participants. And in our beginning in Olmsted County, 400 children have asthma action plans today, which are electronic documents that summarize the appropriate interventions tailored for that particular child, done in partnership with the providers, the parents, and the community caregivers. So, and furthermore, it's maintained up to date, dynamically, and is electronically accessible, so that the providers in the schools can understand precisely what care needs to be delivered. We expect to have 8,000 children by next year, and 18,000 children, which is our projected population for the southeastern Minnesota area at the end of our 3 years, the entire population. Our other hit song is diabetes, in particular patient participation in diabetic management. We are one of, I think, the organizations that are truly experimenting with patient-reported outcomes and participatory decision-making in terms of diabetes care. To coordinate that, particularly to coordinate that across a population, requires the kind of HIT infrastructure that we are promoting and delivering. However, the advantages are profound, because with patient participation, their need for face-to-face encounters, their engagement in the process, particularly with participatory decision-making, is substantial, and we expect to dramatically reduce inpatient visits, emergency room hospitalizations, and of course readmission in more complex settings. This is the panoply of volume to value transition that we see engaging. And in terms of payment reform, we believe that we are establishing not only the providers, but the entire community to really benefit from upcoming payment reform opportunities and alternatives, engaging the population and understanding this, and of course the providers in partnering with it. Thanks.
Great, thanks very much. Jim?
Thank you, Mark. We like to think of our Keystone Beacon Community Award as a small business loan. We believe that the value proposition on the basis of which people are participating in the community is that regardless of payment reform and whatever shape it takes, and regardless of things like ACOs and other administrative structures, the ground reality is that for the rest of our working lives, care providers will be responsible for delivering reportable quality at far lower internal costs. And that is the value proposition on which our sustainability plan is based, is that we are field testing in fragmented, competitive, open community methods to help all of the community's providers achieve those two goals in a way that probably is not possible any other way. So we think of this 3 years as phase one. We have designed all of our interventions as representative beginning interventions so that we've tried to do acute and chronic care. We have patients with 3 different kinds of opportunities to enter information directly into the care system themselves. And the plan is to extend all of those beginning sort of kernel services to additional populations, additional conditions, additional geographies as rapidly as we can get to the point that we understand all the moving processes, moving parts, and make sure that most of the parts are moving the right direction most of the time. We see our customers as patients, hospitals, clinics, nursing facilities, home health agencies, all the other members of the healthcare team, and insurers, and have designed our interventions to be meaningful and to produce meaningful results for each one of those customer groups, so that our sales plan is to go to each one of those customer groups and say, here's what we can accomplish in terms of decreased 30-day readmissions, which matters to hospitals, in terms of reportable quality of care and patient satisfaction and clinician satisfaction to hospitals and clinics and employers, to have a value proposition for each one of those populations that makes it a no-brainer for them to say, well, of course I would buy that from you. I can't get anything like that quality at anything like that price anywhere else. The green shaded piece of paper on the left side of your packet outlines the way that we see sort of the methodology for achieving increased reportable quality at decreased internal cost. You can see that health IT is the glue for all of that, but there are a whole set of other extremely demanding disciplines that require incredibly skilled teams, that require lots of information that is near real time and clearly focused on process needs, not on the fact that someone can produce it and send it. And I'm not going to say too much more about that. Just 2 things quickly. I have been stunned by the fact that in this wide open community where we just invited every hospital, clinic, nursing facility, and home health organization in the 5 counties, every time we have a care process design meeting, more people come. And although I keep pushing the team to hear about trouble, what they report again and again is that there's almost universal consensus and a real will to design shared care processes that all of the participants will help to execute together. The other thing, team executed, the patient is obviously the CEO of the team. The patient hires the team, the patient fires the team. The patient decides whether the team is up to the task and which parts of the team are going to do which things, depending on their preferences. Just a couple of mileposts. We have 1,000 patients that have been enrolled in the active care management part of Keystone Beacon Community. These are high-risk patients for whom we have reason to be confident we can move the needle within the 24 months that we need to do it. We had a large insurer lean over to me during a meeting and say to me, Jim, we need to buy this for central Pennsylvania. So that's our idea of sustainability. The third sort of exciting milepost is we have one participating practice or set of practices who have many locations outside the region and some inside Keystone Beacon community. Their very hard-headed business manager came to us and said, if I would pay for them, would you hire and train and manage your Keystone Beacon care managers for my other practices outside the region? So we believe there is very early reason to think that this thing really does have sustainability legs. Finally, something that we didn't anticipate that's on the green shaded paper when we wrote this proposal is how critical and how early being able to do analytics and feed information back into processes early enough that they can affect the quality of the care process and the quality of patient outcomes, how early that would be important. And so we have added that to our previous portfolio of services that we think are critical to maintaining this. And then the final thing is the demand on teams. This is unbelievably demanding work. We're very fortunate that most of our teams have been doing this for a long time in a lot of different settings. But we have actually had very capable people join teams and find that the complexity, the demand to understand different kinds of customers and their needs, the ability to sort of create the thing while you're flying the airplane is more than some people can take. And so I just add to our experience that this really is remarkably difficult and will take more resource for most organizations than is envisaged in our plans.
Jim, thanks, and go to Sabrina, and that's actually a good point. So we've heard from a number of different Beacon perspectives on the impressive things that they're doing in terms of trying to change care delivery, but also, as Jim just said, this is hard work. It takes some real effort. It takes some funding, and I think a payer perspective here is very important, since that's the other part of getting alignment in achieving these goals.
Thank you, Mark. I'm honored to be here today. I think I am in a minority here representing a payer, so I'm really honored to share that perspective with you. I represent the Crescent City Beacon program, which is the city of New Orleans. And I'm not going to really talk too much about what the Beacon is doing. It has made tremendous strides over the last year, especially the last 6 months. But the concentration of the Beacon in New Orleans is around diabetes and cardiovascular disease, focusing on improving standards of care, information sharing, quality improvement, and introducing measurement across the system, payer agnostic. So I think the way I've explained this is that I'm honored to have my nose in the tent because oftentimes the payers are excluded from the room so that the providers can sort of talk about how difficult it really is to do this stuff and what some of the things that have to happen need to be talked about maybe without the payer in the room. But I think our position is that we know that as a payer, we are truly partners with the providers and we have to help them get there. I want to talk a little bit about the Louisiana environment. It is very much fee-for-service, fragmented, little or no capitation. We're progressing along the health IT side, and quality-based fee-for-service payments are still something that is difficult to pull off in a contract in some cases. So you might ask yourself why, and it's very obvious to me that our providers are just not ready. And that's what the Beacon is all about, right? It's about that light. It's about the light through the end of this dark tunnel, and we are going to get there. So the goal at Blue Cross Blue Shield is simple. We want high quality, low cost access to health care for our customers. We serve the state. we're bordered. Our business is the state and New Orleans particularly. So we have a vested interest in seeing the Beacon be very, very successful. You may ask, so how do you really get there? And our Beacon came together as a group of providers, but it really needed some focus. And the fact that it's focusing on diabetes and cardiovascular disease is not an accident, I don't believe. About 6 to 8 months before, the Beacon really focused on that. Blue Cross Blue Shield opened or announced our Quality Blue program, where we would incentivize providers to become NCQA accredited in diabetes, stroke, and patient-centered medical home. We put a lot of money behind it. And in talking to some of our leadership around the Beacon, who brought us to the table, so to speak, they said, what's important to you? And we had put a stake in the ground on that, or we're really getting ready to do that. And the alignment of the Beacon along those conditions was very much not an accident. So I think that's the value of having the payer at the table early, especially the largest payer. We can all sort of row the boat in the same direction, have the incentives work for everybody, and have the providers and the payers working together. But we understand one thing. We know that somebody's savings is somebody's revenue. And we have to make the payment system work, and that's not easy to do. It's not easy to do from a provider perspective, and it is not easy to do from a payer perspective, because there's a lot of infrastructure that needs to be built to support that kind of payment reform. We are working hard at that and talking to our provider community in trying to get there together. I think another important reason to get your payer to the table, if they're not in a big way, is that as a leader in Blue Cross and Blue Shield of Louisiana, on the strategic side, I'm at the table discussing our planning, our projects. You know, there's only so much resource to go around, even in a health plan. And if we know what's going on in the Beacon, we can leverage it. We can pick projects that leverage the work of the Beacon. So I strongly encourage you all to get your payers involved, and I'm very proud to be involved in ours. I definitely believe it is sustainable, but it will take some work figuring that out together. Our Beacon is in its infantile stages in figuring that out right now. I think we're just trying to get the providers all on the same page, working together, rowing that boat in the same direction. And then once we really have the fundamentals down and some plans that are more concrete, I think we can talk about how to help and make sure that we're working to make it sustainable and purchasable from our customers and by ourselves. So thank you.
Great, Sabrina, thanks. I wonder, based on Sabrina's comments, for the rest of you on the panel, her point about the importance of early engagement with payers to make sure there's kind of good mutual understanding of what kinds of changes in delivery you're trying to accomplish and how that can best be supported by payment reform. Is that a theme that you all, or what's your experience with that theme? I mean, I think it sounds something that sounds good, but actually going about doing it, you know, you've got a lot of other things on your plate too, and that can be an additional challenge. Any tips or insights or lessons about getting payers involved in the Beacon efforts?
Well, we're lucky at Geisinger because we have a health plan who is very sophisticated and a real partner trying to make it perfect for the patient, as Glenn would say.
But as you go
so
beyond...
There are test market, and they're the first people we ask, would this work? What would we need to do to make this useful? But then we have an expert panel that meets and listens to what we're doing and critiques us and helps us improve it. And we have another health plan on that expert panel, and it's an incredibly useful discipline then to have that feedback, because we really, from the very beginning, part of our plan, part of the award condition was that we have a product to sell by 36 months. And so those two ways of working at it are very useful for us.
in Minnesota, we're very fortunate to have, as you know, a very progressive state in terms of health care payment, insurance products, models, provider plans, and the like. We obviously are partnering with them in exploring various test modalities, experimental payment plans, and Doug Wood, who is one of our co-principals investigators, has been our key engagement in that particular community on behalf of the Beacon.
In Cincinnati, we were fortunate enough to be started by 5 health systems and 2 health plans. So they had a position on the board, right from the beginning. But that's 14, 15 years ago. Roll forward to Beacon. I've now got 1 health plan represented on my board, and frankly, they're all around the process. They're participating in a number of the meetings. To my mind, their engagement, their full engagement, in not just sitting in the meetings and looking at what we're doing, but in connecting, in moving toward standardized measurement systems and hopefully connected processes, so the master patient index that we have really equals their member list, and we have data going back and forth both ways. If we can make that happen, then we'll really be able to move it forward, and I believe that we can.
And in Maine, we're starting with the large employers rather than the payers. And in Maine, we have a group called the Maine Health Management Coalition. And that group is a group of the large employers in the state. And so we're working closely with them as we develop our plans, and then we will bring in the payers as appropriate.
Great. I'd like to open this up to discussion with all of you, and I see a few hands up already. So again, as usual, please let us know who you are, and please go ahead with your question. Let's start right there.
Greg Paulson, NCQA. As a measure wonk, 2 things come up out of this. It's really encouraging to hear the stories, and it's both on the patient side and the provider side, but the hard-headed decisions are going to come on real data, and there's 2 challenges I see. First is how close are you, each of you, to having reliable, valid, complete, and believable data for both payers and for the providers about how well your diabetes or cardiovascular programs are actually working. As you know, there's data out there from a couple of studies that show that even very advanced IT systems are not yet capable of extracting in a uniform and reliable way health information. The second, it relates to the points that were made that Mark started at, and that is all this in terms of turning it into a different way of paying for healthcare is only going to work if the reductions in volume and overuse are more than the increases in prices. And I think for the ACO, that's the dead moose on the table that I think insurers are very concerned about. So I'd like sort of perhaps some comments on both of those points.
I will start.
You want to start because you mentioned moose?
Yes, great. We have a lot of moose in Maine. The reliable data, we have had electronic medical records for multiple years. We already have registries. We are patient-centered medical homes, so we have been measuring the NCQA measures for multiple years. And so in our Bangor Beacon community, we are measuring practice-wide data. We have set goals, some of them even higher than the NCQA levels because we were already meeting those. And then we also are measuring for the patients that we're enrolling in our study more specific measures, including quality of life surveys. So we're measuring both at the provider level and the patient level. And because we've had robust electronic medical records for years, we're already used to running those lists that Farzad mentioned and picking out those patients with those diseases. We're looking at diabetes, congestive heart failure, chronic obstructive pulmonary disease, and asthma. On the item about, what was the second question?
Price and net impact on overall costs.
Our goal is to just measure volume. So we're going to measure emergency department utilization and hospital stays, and we'll measure before and we'll measure after. And rather than try to actually get a cost, we'll probably get an average cost and to put some dollars on it.
But you're using the data from your patient care systems. That's what you're going to take to the business community
Yes.
as the basis for the measures for
Yes.
new payment systems.
Right.
You're correct that the data extraction, particularly from the physician office level, electronic health records, very, very difficult. We've done it and done it successfully, but only on a very labor-intensive, frankly, not very sustainable or spreadable process. Because we are also a regional extension center, we're working very, very heavily with the electronic health record vendors, trying to move them to different designs that frankly aren't possible if you don't have an HIE. I mean, every physician group has a different number for the same patient. Well, if they could touch the single master patient index, you could easily move down that track. But it's a problem. We still have to put more work into it. But there's a strong desire to get us to that point. It would be so much easier if we could move all the commercial plans and CMS to the same measures. Is that a theme that's developing? Then it would be more rewarding for all and have much more of a critical mass of physicians to do it. In terms of the price, you're right. One person's revenue is another person's expense for the most part. To my mind, at a community level, there's still some low-hanging fruit. Why does everybody have to buy it by themselves as long as they're part of governance of data infrastructure, for example, to support payment reform? If you trust each other enough, or you trust an entity in the middle to govern it, you can save both the money of investing in it, but also lots of the operational pieces and decisions. And by sitting in the same room, you're going to move toward a more collaborative environment. There is also a big expense associated. I think there's a Commonwealth Fund graph out there in cyberspace that says it's, what is it, $68,000 per physician per year that it costs the physician to interact with the health plan. Wow, I wonder if we can't work on that and get some kind of B2B connections. I see heads going up and down. These are the engineers here. To really make that work in a much better way. That's the kind of oomph that'll really move the sustainability along.
We benefit hugely, again, from the progressive nature of Minnesota. Virtually all of our providers, save one, are in some kind of network. So the number of moving parts that we have to manage for data aggregation and collection is vastly smaller. We're also, of course, using the sharp technologies that we're developing to do, on the one hand, data normalization. We're partnering with Regenstrief and all of our 16 other collaborative organizations in the SHARP consortium to do data normalization so that we're dealing with comparable and consistent information in the first place. We're also in SHARP working with what we call phenotyping algorithms, which, relevant to your question, we're taking the new NQF syntax for numerator and denominator specification and transforming that into rules. That's jargon for stuff that works on electronic health records, so that we're able to generate with high degrees of accuracy and fidelity these measures algorithmically right from the normalized data that is coming out of our health systems in our repository. With respect to payment and price, I'm underinformed on that particular one. I do know that we're focusing on services and clearly monitoring service counts and delivery and volumes, not with a goal, of course, of trying to optimize them, which was the old model, but quite the opposite, which we think actually would result in improved quality.
You're right. The data issue is remarkably stringent. To really provide patient-centered care, you need near real-time data out of clinical systems, you need data from PBMs, pharmacies, you need data from health plans, CMS and others, and you need it all of it fast enough that it actually improves the process, that it didn't just give you some retrospective look at the process 6 months later. And so that's one of the things that makes this incredibly difficult to do. Is to have a team that is sophisticated enough and has enough experience. Actually, one of our advantages is that we do have one set of patients. We actually have all of that or most of that information. And we sort of try to use that model of how we put together information and use it to create analytics that feeds back into the process, and then say, okay, how much of that could we get from CMS and how fast? And how much of that could we get from other payers, and how would we get PBM data in? But to do that well, right now is as much art as anything else, and is very much something that you create de novo.
For New Orleans Beacon, we are in the beginning stages of data exchange agreements. Our focus is going to be on some quality measures related to our two conditions, as well as a focus on ED visits. Readmissions are to come. But I guess I want to say to the savings aspects of it, I like to be optimistic and think that if we can keep trend manageable and out of the 5+ range, we've accomplished something. We've bent the cost curve. We might not have, made it negative, but that's, if we can prove we can do that, then I think that's a value proposition for employers and insurers. And I have to say that it's without grants like this that this might not happen. So it's important to engage in, I think, I'm an actuary by training, so I always like to see the numbers, but I think it also takes a little faith and investment in the future to make all this work.
It does sound like there's really not another source of the kind of cost or spending data that Greg mentioned besides working directly with the payers. I mean, the measures of utilization, readmission, and so forth are good indicators of resource use, but if you really want to get at cost, you're going to need that kind of collaboration and data sharing.
And there are some components of the healthcare system that don't affect really, doctors and even hospitals like pharmacy. We are not effectively using pharmacy benefits. People are not educated. So I think when we think about the opportunities, there's some low-hanging fruit. We got to go after that first, and the tougher stuff we save for later, but we get to it. And I think you have to start somewhere.
Kathy?
One of the things that you find when you collect data and then look at reports is that it's usually not what you expected the first time you looked at it. And so one of the things that we have as part of the Bangor Beacon community is a group of the primary care practices that get together. They share data from each of those practices and look at it and decide what they do to improve. And then put together a 90-day improvement plan and then go look at that again. And the first part, though, is getting the data clean. And that's what you start saying, well, do we really want to include those patients that are over 80? Or it gets very detailed in the discussions. And so that's the first part of the process. And then once you have that data and you have agreed to the definition, then you work on specific performance improvement plans and you learn from each other. And it's just a fascinating process to watch.
And that can involve the payers, too, for the claims data, too.
Right.
Yeah, I have a question up here.
We'll get
Go ahead,
that
Maj.
later.
Maj Dolwan, Leading Age Center for Aging Services Technologies. Thank you very much for the information you provided today. Clearly, the aging population stands to benefit significantly from the kind of innovations that you're pioneering, and a significant portion of care is actually delivered by long-term and post-acute care providers, home health agencies, nursing homes, and so on. And I'm glad to see that some of you are actually actively engaging long-term and post-acute care. I'm interested in learning about the other Beacon communities' efforts in engaging those providers, and also if there's any systematic approach, programmatic approach from the Beacon to extend those learnings and to get the other Beacon communities to engage long-term and post-acute care providers in care coordination, shared care planning, and health information exchange.
In Winona County, which is part of one of our 11 counties, we have what we call a deep dive, where we're experimenting with sophisticated telemedicine implementations that include obviously data monitoring, remote diagnostic tooling and setups, and leveraging care personnel in long-term healthcare facilities, as well as other home healthcare models to deliver the care in the field, obviously by protocol, and when needed, having the opportunity to do a remote, just-in-time telemedicine consult with providers that can ideally allow the patient to receive appropriate care in place without all the expense and discomfort of moving and coming in for evaluation or visit when in fact it may be manageable otherwise. We believe that those methods and techniques will be highly generalizable. Some of us are focusing on the underpinning technology that enables it in health information exchange, but it's also, in terms of payment reform kinds of issues, gets at what becomes reimbursable, what becomes covered, and how do we, I mean, in an ideal system, it would be a capitated model, but that might be going a bit far. At least for the time being, under ACO and related activities, it's going to be on decreased utilization.
Just one quick thing. Every nursing home is required to produce the MDS, electronic documents, send it to CMS. That has a lot of valuable clinical information in it. Every home health organization is required to do the same thing. It's called OASIS in their case. We're working with a senior team at HHS to create clinical extracts of those two documents so that any of those organizations that's connected to an appropriate health information exchange or some other similar thing, the health information exchange we will be capturing the clinical extract automatically every time they send one of those to CMS. And that is available as soon as we get it finished to all the beacons, but also everybody in the country that has the sense to connect long-term post-acute care to the information sharing.
I think we have time for one more quick question, if there is one. And if not, I'd like to thank our panel for a challenging and interesting discussion. You know, obviously, it's hard work to reform care and get the IT into effective use, and it may seem like bringing in payer and employer perspectives through that process is an additional bit of work, but clearly there are pathways to do it, and clearly it's going to have an impact on the sustainability of all the efforts. So thank you all very much for joining us today.